Thanks so much, Pooja, and thank you, Dr. Himanshu Mehta, and the whole IRSI team for this kind invite. And it's really great to be with youthful IRSI, and I hope that I'll be able to share my pulse. So Rohan told me to talk about what challenges I faced in private practice while practicing cornea and what were my learnings. So I'll just take you through my journey and just share a few instances here and there. So this was year 2006 when I got my fellowship degree from LVPI, and from there I straight away came to Ambala. It is a small city in Haryana near Chandigarh, and I declared that I'm going to do a private practice and cornea as primary specialty. And I belong. My parents didn't have much money, so even then I wanted to do a private practice. So I went to my seniors, friends, and they said, cornea in private, are you crazy? And this and that too in a small city. So I said, but why? So they said, this, see, cornea is an institutional based practice, and it is only in big cities, because when there is a complex problems, the patients tend to go in a bigger city. So this is not a good idea. So I spoke further. I said, no, I see, I love cornea, so I want to do cornea. So he said that, see, there are these things you are going to face. They forewarned me. They said, see, tissue will be an issue. It's not that eye banking at that time was not that great. And then they said that there is Human Organ Transplantation Act. At that time, there was a kidney racket, and then there was this eye racket, and so many things were there. And he said that you are coming northern part of the world where it's not a good idea, and you are going to have a good amount of administrative and all those difficulties. And the third thing they warned me was this: see, if you are doing a cornea, it's like you are going to get married with your patient, because you are going to treat them lifelong. And then guarded prognosis, not that it's not going to like cataract next day 6 6, less money compared to your refractive and cataract, you'll have less money. So this was October 2006 when they warned me, and now it's April 2021. So when Rohan told me, so I just looked back in my memory lane and thought that these were the issues that they said. So was this a challenge? So the answer to all three was yes, these were challenges. Apart from this, there was another challenge. Cornea had been changing very quickly. So the learning that too in private practice, this again was challenge. So these were the four challenges which I thought, I have faced during these 14, 15 years or so. Let's take one by one. This has been a tissue dependent branch, no doubt about that. 2006, iBank was developing. There was a lot of work by LV Prasad Institute, Dr. Nagrao. But at that time we used to call each bank. So we used to get tissue, one or two tissue in a month, sometimes one tissue in 2 months. And there were 2, 3 eye banks, Ramayana International or EBAK. So I still remember it was at 2 months out of my fellowship, I got a call from Ramayana International Eye Bank, and Srinivas called and said, Dr. Vikas, do you need a tissue? So I was like, wow, it's like God coming right in front of you and asking you, okay, what do you want? So I said, yeah, of course. He said that, see, we came to know that you recently passed out and we just wanted to help. So at that time, it was very, very, very challenging. Even one call from iBank was big news. So not only the number of graft, another important thing is quality of tissue. So when you are in fellowship, everything has been taken care of. But when you are in private practice, you have to take care of each and everything. So we do get an evaluation form when we get a tissue, right? So this we used to get. So initially what I used to do is I thought that, see, this tissue has been evaluated from RIB, so it's good. So go ahead and do the surgery straight away. But what happened, you can see this was a turbidity in the medium. So this is very, very, very dangerous because it's a fungal growth. This ultimately grew fungus. So there, and this was picked up my assistant. So I learned that, you need to have your own evaluation form also. That's what we started doing our evaluation also before we, accept the tissue or use it for our surgery. I remember this patient, we had posted a DSEC. It was very early on. I was very excited that, I'm going to do a DSEC, and patient had also come. So the patient came before, previous night, and today morning we were planning to do the surgery. Patient had come, he was waiting outside. I was getting scrubbed. And suddenly, my assistant said, Dr. Vikas, just see, what is this in the bottle? So this bottle was broken, so there were transport issues as well. So it was like a heartbreak. You have a DSEC patient lying inside, and you saw that the bottle was broken. So there I realized that, see, it is not just quality you need to take care of, because I don't have an eye bank. So transport can also be an issue. This is very rare. We never had after that, but this can be an issue. Another patient, this was keratoconus, and I had planned I think PK or DLK, I don't remember. So I was getting scrubbed. Patient was blocked. So this again, this assistant said, doctor, see, there's something white in the cornea. So you can see this. There were these white. So what was these? These were actually frozen droplets. They had it, and when they kept the tissue in freezer, so instead of keeping it at 4 degrees. So those things also, then I realized, see, it's not that you can take it easy. I had to ultimately use this tissue for therapeutic. So the quality is also important. That was the challenges. So this was a learning that I burned my fingers and thought that, okay, I need a proper SOP here. So that's what we developed after that. After 2-3 years, CDS came up, and Site Life helped a lot. And I was one of the surgeons where we developed the guidelines for central distribution system. And these days we have just one phone call, and the tissue gets connected to us. So it's far much better as far as eye banking is concerned, but we are a tissue dependent, and this was very well proven in COVID days. In COVID days, the most affected branch was cornea, because the tissue had again gone down to one a month, one in sometime 2 months. So tissue was definitely an issue. HOTA, yes, initially I did a transplant in a center where there was no HOTA registration for a couple of months. Then I realized that I have to get HOTA registration. Then I realized where the civil surgeon sits, what is DGHS, what is HOTA team, and all those things. You had to get into all the nuances, understand everything, and get a HOTA certificate. So is it that if you get an HOTA certificate, all things are done? So no. So I remember we renewed our HOTA certificate after certification after 5 years, and it was done in February. And I was in DOS meeting in April in Delhi, and I got a phone call. There are some administrative people, they have come and they want to check each and everything. And there was media and so many things. So I was surprised and shocked. So what is going on? So we had to simply show. I came back to Ambala. There were a lot of questions that were asked. Where is this Ramayana International Eye Bank? Where is this Kerala tissue and eye bank? So many things. But what what we learned and what could sail us through was good documentation. Dr. Usha Gopinathan and Dr. Savitri Sharma in LPI, they used to stress a lot that you need to have very good documentation. Documentation and support, the peer, your seniors, AIS was a big support at that time. And, we could get over that phase. So it was definitely one of the biggest challenge. But if you have a good documentation, good support from your peer, you can, go through those challenges as well. Third challenge was, which was foremost, was long-term follow-up, guided prognosis, less money. See, it's not that you get this all the time. You have treated a patient who can't see at all, and next day you can see 660, 636, very happy, very gratifying. But as a cornea surgeon, you have to deal with graft infections, graft rejections, vascularization, failed graft, astigmatism, loose sutures, all those things. And then there's a re-terminologies in cornea: reinfection, rebubble, AC reformation, recurrence of infection, recurrence of dystrophy, regraft. You have to go through, and even I went through all these things. And then some patient says, "Arey doctor साहब, कब से आ रहा हूँ मैं, कितने साल हो गए, इतनी सारी surgeries कर ली, कब मुझे दिखेगा?" That also happens. Then sometimes patient asks, "Doctor साहब, मेरा treatment कब खत्म होगा, मेरा इलाज कब खत्म होगा, when my medication will be over?" So these, you have to deal with these patients. And at that time, what happens is, how do you take it? Do you pity these patients? Do you pity yourself that, oh my god, there's so much effort, and then again problem coming again and again? At that time, what I feel is, what matters most is counseling. And counseling of self. Counseling of self is more important than counseling of patient. Do you feel guilty if you see a patient of graft infiltrate? Do you feel guilty if you see a patient of graft rejection? That is very important. So if you feel guilty, the same vibes goes to the patient. So your own mindset, your own body language, that is very important. So how do I tell my patients is, see, this keratoplasty has a 85% success rate. It's amazing. I don't tell them that, it's 15%. Motions, you have become 200. Wow, 200. That's okay. That the context is different. And sometimes, you feel the things are changing so fast. I'll be out of practice if I don't catch up. Versus cornea is such a dynamic field, a lot of learning, and you are always on toes. And if you learn a lot, you'll grow a lot. Monetary gains versus impact. Yes, refractive, it cannot be compared to refractive and cornea and refractive surgery, but impact will be much more. But then what stops you doing cornea and cataract and refractive as well? That also you can do. And rather, as a cornea surgeon, you are likely to have a better understanding of both. So suppose this patient comes to me, and the pseudomonas very bad infiltrate. So I'll tell them, see, I'm going to do a transplant which is going to solve this infection problem and not the vision. So once he sees next day, so I tell them, okay, patient, I just tell him to see, your infection is over, congratulations, but vision that you are seeing is just a temporary one. And when he'll have a graft rejection, I'll say, it's okay, congratulations, the infection didn't come back. In close to 5 to 50% of patients, the infection can come back, but you are so lucky that the infection didn't come back. It's fantastic. All we are going to do is change a few cells of your eye, and this cornea will remain same. And when we do a DSEC in same patient, it becomes so clear. Again, we tell them that, see, it is possible that your vision may fluctuate, but again, we'll take care of it. In case later on this gets rejected again, we can simply change this cell, just like we change the battery of a watch. So important thing is how you are presenting these things. And before that, you need to be really confident, your conviction for yourself that you are doing these particular surgeries. And there is, if the patient has a graft in field, it's not your fault. The 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 disease per se, the treatment per se has its nuances, and you have to go through it. So it's important to just think what I'm going to do now. So even then, whenever I feel low, I tell myself that, you see, cornea was my choice. Nobody forced me to get into it, and I knew the path beforehand. So better to focus on what needs to be done at this moment. If it's a rejection, okay, I'll just think that, okay, instead of saying, oh my god, again rejection, again has come, patient has come back, instead of said, I'd say, okay, there's a rejection, what is the treatment? There's steroid, systemic or topical, just do that part. So, and the last challenge was cornea changing very quickly. So how do you learn in private practice? So difficult to learn in private practice. I'm not in a charitable center, I'm not in a common setup, there are no free patients. So how do they learn? In 2006, when I came out, it was only penetrating keratoplasty. So I had learned only penetrating keratoplasty. And 1 year into the practice, this thing DSEC came up. Rather, I was just telling Himanshu that it was because of that conference in which there was a DLEK was shown. I thought that, a cornea is my love and I want to do cornea. So 1 year into practice, I decided that I'll do DSEC, and there was no one doing DSEC in this particular area. So I had seen a few videos of Dr. Fogla and Dr. Mark Terry, but not much. So I went for AO meeting in Singapore, and there I saw Donald Tan DSEC videos. And when I came back, I decided that I'm going to do it. I requested few rejected tissues from Hyderabad, did arranged a wet lab on my own, and just got a feel of dissection, that what level I'm in cornea. It's a half, 2/3. So after getting that, I posted my first patient. The first patient was DSEC plus phaco, and guess what? He improved to 6.9. He's still maintaining 500, 400 cell count. The thing is, I couldn't explain him. I was pretty nervous that this was the first patient, although we didn't charge much. So I tried to explain him, see, if the surgery doesn't go well, we are going to do a penetrating keratoplasty. The patient was from a poor background. So I thought, let me present it in a different way. I told him, see, we are going to do your surgery in 2 phases, phase 1 now and phase 2 after 3 months, and you will see after 3 months. So I just wanted to secure myself that in case it doesn't work, this penetrating keratoplasty, I was well trained in penetrating keratoplasty, and there was something to fall back on. But fortunately it did well, and after that we absorbed this DSEC into our practice, and we kept on doing training as well. And DSEC became a part and parcel of my practice. 2 years into my practice, this I wanted to do a stem cell transplant, which I had seen in LVPI, but I needed a stem cell lab, which I didn't have. And then I was talking with Dr. Sangwan in faculty lounge at LVPI, and he said that, see, I'm doing this new technique, where I place these explants directly on the eye. So I thought, oh, this is very simple, I can definitely do it. I came back to Ambala and did my first select. That was 2007. in 2010. That was even before the first. Why I don't learn it? So there was a very good how can I do it? And then I had with Dr. Mellis and started doing DMEC. After initial hurdles, DMEC, and then 6 to 7 years in my practice, there was a KPRO workshop at LVPI, attended with Sangwan, Dr. Chain Chodosh. It was amazing. And then MMG, I learned from Dr. Sayan. He's a very good friend, and Sayan was, kind enough to let me enter his OR. I spent 2-3 days and then came back, started MMG and KPRO as well. So in fact, after that, we organized this workshop, ocular surface workshop, which was exclusively on Stevens-Johnson syndrome with people from all over globe. We had Dr. Chodosh from Harvard, from Japan, from China. This was a hugely successful meeting. And recently, we have included, we have started doing Bowman layer transplant for some keratoconus patient, and our series is going to be out very soon in JCRS. So, not only I learned these surgeries, these days I'm also learning how can I make someone learn. And we started our long-term fellowship program in 2019, and this again is an amazing, and thanks to Himanshu, who actually nudged me into it. I have been discussing with him, so I want to start it, and he simply pushed me into it, and I'm definitely enjoying it a lot. So even in private practice, as you can see, you can learn. So I learned D6, SLED, TMEC, MG, K-Pro, Bowman layer, and fellowship, everything in my private practice. So yes, there were challenges. Tissue was an issue, HOTA, long term, all those things are there. But Ruchi, she's my wife, and she's a retina surgeon herself. She always says that because cornea is your first love. So of course, officially, I can never agree with her. But challenges will be an opportunities of growth if you are passionate and if you really love it. I thank my mentor, Dr. Sangwan, who has been with me all through all these challenges, and then Dr. Chandrakar, who this team is from my PG days, and Dr. Jim Chodosh and Malice, whom I see that they are one of the wonderful teachers I have seen so far. Thank you so much, and thank you so much once again for this kind invite.
Fantastic, Dr. Vikas. Absolutely brilliant, right from the heart presentation. What a
Very
journey.
inspirational for young ophthalmologists to start out, that even though we know we have challenges and how to battle it, and mentally prepare yourself that no field comes on a golden platter. You have to face challenges, but having a positive mindset and how to go about with it, I think it's very encouraging.
Absolutely, Pooja. Thank you so much. Thank you so much, Dr. Mehta.
Long struggle, but brilliant struggle. It's worth it. End of the day, if the struggle wasn't there, the fun will not be there.
Absolutely.
Each of these stories have a great, great story behind it. All the best to you. I mean, brilliant. No
Thanks.
questions, no questions. A great journey, and something for anybody to take pride of and follow and mime you actually somewhere. What do you say, Gaurav?
Yeah, I've been following Vikas's journey right from the time he started his practice, and he's been a regular at our UKSOS conference. He's initially used to come over as a very young dynamic surgeon, and he's now coming as one of our chief instructors. And it's so comforting to have Vikas just 150 kilometers away. It's so easy for me to just tell my bad cornea patients to just go, and I tell them that don't worry, once you get there, you won't have to think again, because so he's been really serving the whole territory of North India. And now I think Vikas is at a different level altogether. He's on the national stage, fully there and doing tremendous work. And I'm really excited about his latest publication. I told him about a year back that this is big, and today he told me that it's getting published. I'm so happy, and because you've done brilliant. And I think today's talk was really good because it could inspire a lot of youngsters who tend to otherwise think that cornea, fellowship and cornea speciality and practice in private practice in cornea may be very difficult. I think because you've shown the way that how to actually go about maturing as a cornea surgeon and making it big eventually. So excellent. I really enjoyed it.
Thanks so much, Gaurav. Rather, that was my first presentation was in Dr. Gaurav's meeting only. It was UK, so I remember that. Thank you so much.